go. Thank you so much for joining. I'll go ahead and introduce our first presenter. I'm going to get her slide pulled up here shortly. She is a wonderful, kind human and a kind voice to all of her staff and to her patients as well. She has 14 years of experience, and she will be up here presenting on immunotherapy and the microbiome and the melanoma. It is going to be Dr. Teresa Medina. So if you'd please help me join her onto the stage. Here you go. You're welcome.
How do I do?
Just the space bar right here. Space bar. Okay,
Thank you. All right, good morning. So I am going to really present a lot of aggregate data that's been done at from some really smart investigators, a lot of hard work across the country. And these are my disclosures. So as Sam was saying, really the last decade has been so exciting for melanoma patients and the improvement in outcomes that we see amongst patients with advanced and metastatic melanoma. Really, we've seen so many new therapies that have dramatically improved the lives of patients. And as you can see up at the top here, the expected overall survival for patients just continues to improve. And I'd like to just highlight this combination regimen, ipilimumab and nivolumab, that was approved in 2015, where we think that there is actually potentially about 50% of patients that are cured with this therapy. And below the timeline here, I listed most of the approvals and indications of these immunotherapies in the adjuvant setting. And so in this day and age now, we have the majority of patients diagnosed with melanoma that have access to these immunotherapy options. And as a culmination of that, we've seen a significant improvement with much better prognosis for patients diagnosed with melanoma. But for rare melanoma subtypes, I would say we're still below where we want to be. A lot of the trials that have been done looking at these immunotherapies either excluded patients with rare melanoma subtypes, or they're just such a small component of the larger group that it's harder to know how effective these therapies are for patients with rare melanoma subtypes. But when we look at the patients that are treated with these immunotherapies that do have these rare subtypes, we know that the outcomes are not as good as what we see with patients who have the more common cutaneous melanomas. And that's as a group. And then we can also look at the individual types of therapies that we use for these patients, and we can see that there's a trend where combination therapy may help to recover some of the poor responses we see, but still we're below 50% and obviously below where we want to be. This was a slide that I put in just because you guys are all familiar with the immune cascade and all of these different mechanisms, so I don't need to explain this, but really I thought that this just kind of highlights how complex the immune system is and how many variety of different ways that the tumor cells can evade your immune system. And so it's quite complicated in how we can overcome our deficiencies. To make things more simple, when we look at these immunotherapies, we call them immune checkpoint inhibitors. So really, these are antibodies, and we think that there's a couple of different ways that they can activate our immune system to fight off cancer cells. So within a cancer, you have the cancer cells, but you also have these infiltrating immune cells that are there that recognize these cancer cells, but they're just not fighting them off. And one of the reasons is there are these signals that basically turn off the immune response. One example is this signal that we call PD-1. And so the antibodies basically can disrupt that interaction. And so they're turning off, or I should say they're blocking a turn-off signal for the immune system. And so it's a little counterintuitive, but if you're turning off a signal that suppresses the immune system, then hopefully then you'll stimulate the immune system. And so one of the ways these interact is within the tumor itself. A separate way is that there are interactions between different types of immune cells, and the checkpoint inhibitors potentially could help stimulate this activation signal and recruit more immune cells to the tumor. When we look to see why these therapies don't work, it's also quite complicated, as I mentioned. And there can be problems both because of the tumor itself and the cancer cells. There can be problems with what we call the tumor microenvironment, which is the relationship with the cancer cells and our immune cells. And then there also can be factors outside of the tumor itself that are just related to our other health factors. So if we look at the tumor, we know that there can be problems where the immune cells can't get into the tumor, thereby they can't attack the cancer cells. Turns out there's actually immune cells that might be in the tumor that are stopping the immune cells from working, so highlighted by these sort of stop sign cells. There can be disruptions in these molecules that we call cytokines that might help to stimulate more immune cells to come to the tumor to fight them off. There may be genetic alterations in the cancer cells that suppress cytokine production. And then there may also be factors that the tumor can increase, like by inhibiting immune cells from being able to escape out of blood vessels into the tumor. They might increase some sort of a scar type appearance that we call stroma around the tumor that can prevent immune cells from invading. So there's lots of different ways, just even within the tumor, that can be a problem. When we look at outside factors, there are things that we can control and there's things that we can't control. We can't control how old we are, and we've been able to show that there is a difference in responses based on people's age, their gender, and then other comorbidities such as autoimmune conditions. There are some factors, though, that we can modify, like our diet and exercise, to some extent stress as well. And then what I hope to focus on is the role that the microbiome can have on these immune responses. So I'm not sure how many of you are familiar with the human microbiome, but this is something that's been increasing in appreciation and its role for our general health. It turns out that as humans, really we're outnumbered by microorganisms in our bodies. We have over 100 times more bacteria in our bodies than we do our own cells. And we have lots of different types of organisms, bacteria, fungi, and viruses that live amongst us, and they really are there in all places of our body, our skin, our respiratory tract. And looking at the role of the microbiome in human development and human diseases, really focus on the microbes that make up the GI tract. There have been several studies that have shown that there's an association of our microbiome that influences a lot of our diseases that we can develop, like diabetes, autoimmune conditions like inflammatory bowel disease. People who have asthma or eczema can also have an impact by their microbiome. There's also been shown that the microbiome can influence cancer progression, like in colon cancer and pancreatic cancer. And recently in an animal model, they were able to show that disruptions in the microbiome of the skin and the GI tract was associated with melanoma progression. So you might think it's gross that we're covered in different organisms, but actually these are really helpful for us. And so there's a lot of ways that these organisms help us. They help to train our immune system. They help us synthesize vitamins that we need. They help increase the metabolic components that we need for our body to function. They also protect us from other organisms that might cause really serious infections. And they also can activate toxic substances and protect us from potential poisons. We first started noticing this really interesting relationship between melanoma and immunotherapy and the microbiome from these two studies that were presented in 2015, looking at the role of the microbiome in mice models. There was a study that was done in France that showed that if you looked at mice that were raised in a germ-free environment, meaning they did not have a significant amount of microbial population, they did not seem to respond to immunotherapy as compared to mice that had kind of broader range of microbiome. There was a separate study that showed that you could take mice that were genetically identical, but they were just purchased from two different facilities. And when they looked at the mice after they injected melanoma tumors and exposed them to our checkpoint inhibitors, there was a population of mice from a facility that did not respond to these immunotherapy agents as well. And they found that there was really one striking difference. Their microbiome was completely different. And so they were able to show that if they took the mice from the facility that did not respond to immunotherapy and gave them the microbiome that the other mice had, they could restore their responses to immunotherapy. Subsequently, there was a study that looked at humans to see if we could also see a difference in the microbial population between responders and non-responders. And this just shows on the right-hand side how you can cluster certain organisms in patients that respond, highlighted by blue. And those are very different than the population that you see in patients who do not respond to immunotherapy. You can also look at how patients do in regards to their cancer. So this is what we call a Kaplan-Meier curve. And so what this is demonstrating is that the people who have a high diverse microbiome had significant improvement in their survival, where they had less recurrences of their melanoma compared to patients who had a lower diverse microbiome. These have been subsequent studies that have been done at several different centers. On the left-hand side, we have a study that was done in Pittsburgh. In the middle, we have a study that was done in Chicago. And on the far right, this was a study that was done in France. And I'm just showing you this to show you that when we look at the types of associated with responders, and so it's not quite clear yet which bacteria we actually need, or if it is a particular group of bacteria that is similar amongst all of these different locations. In this top left corner, I also just wanted to highlight that one thing that's been shown to be very important is the diversity of the microbiome in immune therapy responders. So the more variety you have in these organisms, the higher the association of better outcomes with immunotherapy exposure. So given the differences that we see in these different reported bacteria amongst the different locations, this was a study that was done using a specific computer model to try to, again, incorporate the bacteria that have been described associated with responders versus non-responders, and then also in different cancer or tumor types as well. So this is very busy, but basically what this is showing is this is what we call a forest plot. So the line down the middle here, if you have the boxes to the right-hand side of this line, it shows that the organism listed above is associated with response to immunotherapy, whereas the boxes to the left of the line demonstrate that they're associated with non-responders. So you can see in this top left corner that the Fecalibacterium presensii has been associated with responders and non-responders, which makes it quite confusing. So how can we modify the microbiome to improve responses? Well, one way we can do that is by doing what's called a fecal microbial transplant. And this is actually a therapy that we do to treat certain resistant infections. But this has been investigated as a way to try to restore or improve immunotherapy responses amongst patients with melanoma. So this was two different trials that have been done looking at the role of fecal microbial transplant in patients who did not respond to anti-PD-1 antibodies. On the left-hand side is a study that was done at Pittsburgh. They had patients who were treated with pembrolizumab or anti-PD-1 antibody that did not respond. And then they were treated by fecal microbial transplant and continued on pembrolizumab. So you would not expect that just continuing the pembrolizumab would be enough to restore an immune response. So this is to highlight that just by changing the microbial composition, you may be able to restore immunotherapy responses. And down below, this graph is what we call a spider plot. And so each line represents a patient after they've received their fecal microbial transplant. And what you can see is as the lines drop below this 0 marker, it's demonstrating that patients are either starting to respond to pembrolizumab or their disease is improving or slowing in growth rate. And so they showed that 6 out of the 15 patients that received a fecal microbial transplant were able to show some clinical benefit just by changing their microbiome composition. On the right-hand side was a similar study that was done in Israel. Again, patients that were PD-1 refractory and then underwent a fecal microbial transplant. And again, you can see that post-transplant, there were some recovery of responses. And there was actually even one patient that developed what's called pseudoprogression, which you can see on their PET scan images below. So before they had their fecal microbial transplant, they had all of these dermal metastases on the leg. It significantly worsened after the transplant, but then improved, and then they went on to develop a complete response. So the microbiome really is one of the few things that we're able to really have control of and modify. And we know that there's several different ways that we can modify the microbiome. We can control or change the microbiome based on our exercise, our sleep patterns, nutrition, antibiotics. There's multiple different ways that we may be able to impact our own microbiome. So we know that fiber has been shown to be a very important resource to try to improve the diversity of our gut microbiome. And we know that when you have a high fiber diet, you increase a breakdown product that we call a short chain fatty acid. And this has been shown to be very important in immune responses and immune training. And so at MD Anderson, they did a trial looking at their patients treated with immunotherapy, and they asked them what their average daily fiber intake was. And they also asked them if they were taking any probiotics. And what they were able to show is that if you had a patient that was saying they, on average, ate a sufficient amount of fiber, which is quantified as 20 grams per day of fiber, their responses to immunotherapy was better than people who had an insufficient dietary fiber intake. They also showed that the patients that took a probiotic did not seem to have as good of immune therapy responses as patients who were not taking a probiotic, although this was not statistically significant. But when they looked at the patients that took a probiotic and had sufficient fiber intake, you could see there was a reduction in the immune responses just by the addition of a probiotic. This is a trial that basically was demonstrating that there is a change in the microbiome over time. Most of the studies that have been done have really been looking at one capture in time of from patient samples. And so this was a study looking at what happens if you look at the microbial composure over several weeks while patients are on therapy. And they could again demonstrate that there is a difference in the patients that respond to immunotherapy, highlighted by the blue cluster, compared to people who do not respond. I'm sorry, the responders were in the red cluster, I'm sorry. And then what they demonstrated was that if you looked at about 10 months from the time that they started therapy, that's when they could see the concordance of these immunotherapy responses and these microbial clusters the most. And so there's something that happens over the course of time on therapy where you can see these changes in the microbiome collection and then the subsequent responses. They also looked at what influences the microbiome might have on immune therapy toxicities. Unfortunately, this does limit patients' exposure to immunotherapy. And they were able to show that people who developed immune therapy toxicities did seem to have a higher proportion of a bacterium that we call streptococcus. This is not strep that causes strep throat, it's just a similar strain. But they were able to show that if you had a high density of streptococcus in your gut microbiome, you had a higher rate of developing immune-related toxicities, and unfortunately also seemed to have lower or a higher rate of recurrences or lower response rate. So one way that we think that the streptococcus may be increased in your microbiome composure is by PPI use, proton pump inhibitors. We know that by increasing the pH level in the stomach, it may then be a way for the streptococcus organisms to survive from your mouth as it travels down to the rest of your gut. So at our site, all of the studies that I've talked to you about really have just been looking at a group of patients with melanoma in general, and there's not really been a focus on how the microbiome might impact patients with rare melanoma subtypes. So our research, led by Dr. Robinson and Dr. Kautz, is looking at the role of the microbiome in these rare melanoma subtype progression and the role of immunotherapy and changes of microbiome composition. So do you have any control over your microbiome? We don't know if this really is going to improve immune therapy responses. All we can say is that people who do have a high fiber intake do seem to have a higher response. It's associated with a higher response rate. And so I just put here some examples of how you might be able to increase your dietary fiber intake and the recommendation of trying to get to that 30 to 50 grams per day. And then I just like to liken the immune therapy responses in melanoma and other cancers as this ecosystem. So the microbiome really is only one part that we can modify, but there are several other ways that unfortunately our ecosystem needs other factors to improve outcomes with these immune therapy agents. And I'd like to thank you for your attention, and don't forget your sunscreen.